joining today's virtual education program with Cancer Support Community Los Angeles. I'm Larissa Montalvo, and I am the Program Manager at CSCLA. I welcome you to this webinar titled Brain Cancer, What's the Latest? Today, we'll be joined by Dr. Lisa Chaiken of City of Hope and the Pacific Neuroscience Institute to learn about emerging therapies and the latest updates in the diagnosis and treatment of brain cancers. Before we begin, if this is your first time joining us, Cancer Support Community Los Angeles is a premier nonprofit organization providing vital social and emotional support to families facing cancer, including patients, caregivers, and their loved ones, all at no cost. Our programs include support groups, healthy lifestyle classes, social activities, and educational programs such as this one. If you'd like to learn more about our services or watch our past webinars, please visit our website at www.cancersupportla.org. So without further ado, I would like to welcome today's speaker. Rated one of America's top doctors year after year, Dr. Lisa Chaiken brings 30 years of experience in radiation oncology to City of Hope. Dr. Chaiken is well-versed in all forms of radiation treatment and specializes in breast, prostate, central nervous system, head and neck, and gynecologic cancers. Harvard educated and a member of Phi Beta Kappa, Dr. Chaiken received her medical degree and subsequent training at UCLA. Dr. Chaiken is an active volunteer and public speaker with previous leadership roles in the Bay Surgical Society, American Cancer Society, and the Women of Color Breast Cancer Support Group. She is past president of the Southern California Radiation Oncology Society, and she currently chairs the Cancer Committee and Breast Tumor Board at Providence St. John's Health Center. Welcome, Dr. Chaiken, and thank you so much for being here today.
Thank you so much for having me, and thank you for all your good work. So thank you for the kind introduction. I'm part of the City of Hope Medical Group, but I also work at Providence St. John's Health Center, where we provide the radiation oncology services. And part of that is the Pacific Neuroscience Institute, which is part of Providence St. John's. And we have a very active neuroscience program. And there are, of course, a lot of very exciting things going on at City of Hope. So we're going to talk about everything today. And without further ado, I just wanted to show a picture of the City of Hope campus. It's out in Duarte. It's a very beautiful campus with a lot of gardens and just a very peaceful area for people to come and get state-of-the-art care. And we're very happy to have both City of Hope and Providence St. John's, available to you. Just some basic facts about brain tumors. There are about 700,000 people that live in the US with a brain tumor, and the majority are actually benign tumors, but about 30% are malignant, cancerous tumors, and we'll be talking about both benign and cancerous tumors, because sometimes just because of the sensitivity of the brain tissue, we do end up treating benign tumors. So they get surgery and radiation, and sometimes even some medications. Of the malignant tumors, the most common type is the glioblastoma. That's a high-grade brain tumor arising from the tissue in the brain. And that's something that I want to spend a little time on today. It's one of our most challenging tumors because it is a very diverse, heterogeneous tumor. It sometimes can escape, or oftentimes escapes, conventional treatments, and there's a lot of trials and programs going on looking at these, and I'll show you some of the very latest, even from last week, that we're involved in. And sometimes tumors can be asymptomatic and just picked up incidentally on an X-ray, and sometimes there could be a very acute onset of symptoms, a neurologic finding. It's always important to, think, does a patient have a stroke or another issue going on? And sometimes patients present with seizures, which is a very acute event out of the blue. Seizures can come from other causes, but when they come from tumors, because it's so dramatic, patients get in for medical help, and there's imaging of the brain, and we often discover these tumors even a little earlier. And treatments are usually multifactorial, multidisciplinary, meaning that a lot of different ways to approach it, through surgery, through radiation, chemotherapy, other medical treatments that are targeted, sometimes even hormonal, medical devices, and even implants of devices into the brain to help control these tumors. So there's a lot of different and very exciting things going on, and patients have been doing much better overall with all these tumors because of the advances in care throughout the decades. And we'll talk about some of the latest things with that. So primary brain tumors, these are brain tumors arising from the brain, not from a tumor elsewhere that spreads to the brain, um, are, a variety of lesions, and they could be benign versus malignant. So gliomas, those are tumors arising from the glial tissue in the brain, are malignant tumors. They can be a variety. They could be very low grade, grade 1 or 2, which are usually in younger populations, and grade 3 and 4 are the high grade gliomas that we treat very aggressively. And meningiomas is a benign tumor, typically of the lining of the brain. The area that lines are the target or the structure of the brain is the meninges. It's a thin filmy membrane, but they can also create tumors. And some of those rarely can also be malignant, but most of them are benign. They're the most common ones that when someone goes in for a CT scan for another reason, maybe they fell or maybe they had some kind of symptom, that will pick up a meningioma incidentally. And they're not always treated, but they can be if they're symptomatic or in a more worrisome area of the brain. Chordomas are bone tumors, sometimes at the base of the skull. They often take very high dosages of radiation treatment and surgery. And they're one of the few tumors that we actually will think about if they're malignant, sending out for more aggressive treatment like proton treatment. And lymphomas, which are a very different type of tumor we usually see in the lymph nodes in the body, but there can be primary central nervous system lymphomas too that are treated with medications. They're very sensitive, and sometimes some radiation therapy in addition, depending on the protocol. And one thing at Providence St. John's that we see a lot of, because our neurosurgeons are so adept at operating on these tumors, and it's a very major part of the program, are pituitary tumors. And these arise in the gland of the pituitary at the base of the skull, kind of at the bottom, if you think behind your eyes, where the bony structures are before you go into the sinuses. There's a master gland, the pituitary gland, and these tumors can sometimes secrete hormones. It really controls a lot of our hormonal regulation. And sometimes they can just be tumors that don't really have a hormonal, they don't do anything, but they provide bulk and they provide pressure, or they can result in pressure on optic structures, the nerves of the eye. And so they will be taken very seriously and can often have surgery and radiation treatment. So I'm going to be jumping around between different tumors and from the very aggressive to the not so aggressive, just to give you a whole flavor of things. And then the other part that you might see even more often is brain tumors can also be metastases from other sites of the body and a different tumor origin. And sometimes that can be confusing to the patient, that if they have a tumor in the brain, they don't realize it might have been from a previous breast cancer or lung cancer. Because breast cancer is so common, it's one of the most common cancers in women. It's not that it very often goes to the brain, but because there are so many patients that have breast cancer, we do see it as a lesion that can spread to the brain. And some breast tumors have a little higher propensity to do this, such as the HER2 positive tumors. But we don't typically screen. It's still a low incidence, except if patients are, symptomatic. Lung tumors have a very high chance of going to the brain, depending on the type of lung cancer. Small cell lung cancers have a very high tendency, sometimes even 40, 50, 60%. And it's one tumor that we even think of treating the brain preventatively. But non-small cell lung cancers, and it's just a difference of their tumor type under the microscope, can end up in the brain, spreading to the brain 25, 30%, and they can be targeted with radiation. And these patients can do quite well. And with just targeted treatment. And we have a lot of drugs that are used now for breast, lung, all these tumors that really protect the rest of the brain. So we'll talk a little bit more about that later in the program. Kidney cancers tend to have a little higher risk of going to the brain, and melanomas too. So, but we also have very good drugs for these tumors as well, and we can spot the areas in the brain that are involved. Lymphomas, again, can spread from the body to the brain, and virtually any tumor could result in being in the brain. Gynecologic tumors, gastrointestinal tumors, urologic tumors, sarcomas, which are soft tissue tumors. And sometimes when we see something, if we can remove it safely, if it's not in a very sensitive area in the brain, we may decide to remove it just to make sure that we know it's actually from that tumor and not from a primary tumor. And sometimes we have seen patients that could have both a history of another cancer and still have a new primary brain tumor. So we use our clinical judgment and what the tumor is and how likely it could be to spread to the brain and how risky the surgery is in terms of neurologic function. So it's a whole team approach in analyzing things. So again, presenting symptoms are usually neurologic symptoms. We have to make sure the patient isn't having a stroke, and that could sometimes mimic a tumor. It can depend on the area of the brain. Some are with vision or motor or sensory strain. So we need to look at the symptoms and correlate it with what we see, but any neurologic symptom is possible. And certainly patients that have seizures will usually get in for medical attention fairly quickly, but not all seizures are related to tumors as well. They can be related to high temperatures, stress. I mean, there's a lot of different things that we have to take into account. So when we work patients up, we want to make sure that we do some imaging. A CT scan can look if there's an acute bleed, which is very important, can be the start of a stroke workup as well as a tumor workup. And an MRI really gives us definition for looking at the brain. There's a PET scan for the body, but there's also a PET scan for the brain that can help distinguish between scar tissue or active tumor. And these are usually further down the line. We'll use the PET brain test to see how a tumor or how a treatment is working, how a tumor is responding or a treatment is working. Certainly blood tests to look at tumor markers, to look at other physiologic factors or electrolyte disturbances that could cause a neurologic evaluation. And sometimes even a lumbar puncture to look at the fluid that bathes the brain, because this can be infected, this can be involved with tumor, and that would be a very different approach. A detailed physical exam, and then a history of other tumors to try and see if what the abnormality is related to something else or primary to the brain. So I just wanted to talk a little bit about pituitary tumors because it's a very small gland at the base of the skull. And there are tumors that secrete hormones, the endocrine tumors, and tumors that are just inactive. And usually surgery is the main treatment by a neurosurgeon that's very adept at doing this. And we're very fortunate to have a great team, both at Providence, St. John's, and City of Hope. And we often come in with radiation, which is what I do. I'm a radiation oncologist, at either when these tumors start to grow back, or maybe they're not responding as well to other methods, either medical methods or surgical. But these can be pretty impressive tumors. This is an X-ray and MRI. This is the side of the head, and this is looking straight into the head. And this large area that's very lobulated actually can grow out of the pituitary, and it can put pressure on the optic nerves, the optic chiasm, where both eyes, nerves from both eyes cross, can be very thin and up at the top. And these tumors can be very safely resected, often going through the nose or other positioning that's not very radical or invasive. And they can come down to just sometimes a very thin rim and sometimes very, very little residual left. And in this particular example, so this was the first post-op day, very successful. And then this patient grew a little bit and then went on to have radiation treatment. We usually, because this is such a sensitive area, we give it over about 5.5 weeks or so to this area in that range, and at small dosages, because there are a lot of nerves and the normal brain and optic structures all in here. And what you can see is that because these lesions are essentially benign, they don't melt away. They can be removed by surgery. But in 3 months, they shrink a little bit. But patients sometimes expect them to resolve completely, but the shrinkage is small. But that doesn't mean that the treatment isn't working. It's working quite well. And as long as we see stability, that's really the main thing that we look at. But you will see over time and over years, which I think my next slide shows. Oh, this is some of our planning. So this is an MRI scan. We use an MRI to plan on, but our computer likes to calculate off a CT. So we actually fuse both pictures together. And this is at the area at the base of skull. And these are the orbits and the optic nerves. So we're taking into account the doses. These are different doses of radiation with 100% dose covering the whole target. And then it's a rapid fall off so that instead of treating everything in a box-like plan, so that the eyes and everything would get the same dose, this is very conformal or stereotactic, but broken down into small dosages. And this is just it on the CT scan. We use both. We draw on, again, the optic structures and the brainstem, and the ears and inner ears are here. So the dose is really going away from anything that's sensitive. And fortunately, the other structures can tolerate much higher doses of radiation, and we can deliver this very safely, and patients can do very well over time. Sometimes they will lose some endocrine function, so they have to be followed by an endocrinologist, and they will be monitored to make sure that all the hormones are in balance. But that may not happen for several years, and it may not happen at all, or just a few, but they'll usually follow closely, but do very well. And again, we sometimes see that even the imaging response is slow, because I know patients, and I would too, can get very intense over the x-rays, and the expectation, we like to see things disappear, but these types of tumors are benign. So even before treatment, it can be bulky. It will still show up at 5 years, but as long as this is stable and patients are not having symptoms, then it's very successful, and that's a sign that the treatment worked. So we look more for stability and very slow shrinkage. So now we're going to change gears to a much more aggressive tumor, and that's malignant. The ones I showed you were benign, but just in a very delicate location in the brain. So we have to be very careful with them. But this tumor, glioblastoma multiforme, is the most aggressive of the malignant brain tumors. On a scale of 1 to 4, where 4 is the most aggressive, these are the grade 4s. And they've been the most challenging to treat because, unfortunately, they can come back despite standard of care treatment, despite aggressive surgery and radiation and medications. And so we're always looking to see what we can do to make our treatments more successful. But typically the standard is to do surgery to try and resect as much as possible. We find that with surgery, the better the surgery that can be done, the more that patients will just do better in general. So if we can resect, a full gross total resection, those patients will usually do better than patients where only a small area can come out. But it is based on safety. So if it's really going to impact someone's neurologic status, then we will follow up with the radiation. We always follow up with radiation, but we'll certainly be using radiation to target the areas that are left behind. And Temodar is a very common medicine used for this type of tumor. And it's a pill that's given both with the radiation and after the radiation that has been found to really make the radiation more successful, as well as allow patients to just respond better to the treatment overall. And they usually take it for 1 year, but in a more concentrated setting afterwards. And I think this is really key, that we are always looking for clinical trials. We're always studying things, both at Providence, St. John's, and the Pacific Neuroscience Institute at City of Hope, to look at new things, experimental things that could be added in addition to the standard of care treatment. And again, surgery is very important, but not all tumors are fully resectable. And that's why a scan is always done the day after surgery to see what's left. Is there something that someone could go back in and resect, or is that our new baseline for going on in the future? And we're really learning about the genetics and the biology of these tumors through different stains and markers. And if a tumor is methylated, it's a particular thing that we look for, that there's methylation of the tumor. And that's usually a very favorable prognostic sign. We look at BRAF and EGFR mutations on glioblastomas, and these have been used. BRAF has been seen in melanomas, EGFR in lung cancers. So we can sometimes use the drugs that are targeted for those tumors and apply them to brain tumors, and that's been very helpful as well. And more are being studied, and we could do a whole genetic analysis on the tumor, which can be helpful because sometimes tumors do harbor different changes and mutations that there may be a pill that would, or an IV that would not be obvious just from the diagnosis of the tumor. And we'll continue right along. So this is an MRI X-ray of treating a glioblastoma tumor. And the main tumor is here. Some of this white that lights up is just some fluid in the cavity, but it's a bigger margin than what we would treat for a lesion that comes from somewhere else and spreads to the brain. But we want to make it anatomically to make sense. So this is the front of the face. This is the back of the head. These are the eyes, and it's in this kind of midbrain area. And the red is 100% coming around it. And already at a short distance, there's 50% of the dose. So we keep all the optic structures well below it. And I don't know if you could see this faint green line, but it curves around the eye so that we don't give too much to the lens, because the lens is very sensitive to radiation, and patients can get a cataract as a side effect. But even a radiation-induced cataract would not be any harder to treat than any other type of cataract from age or other situations. But we really try and spare that dose, and we have guidelines for that. And of course, we're sparing the whole other eye. And sometimes these tumors are really on one side, so we'll really cut the field at the midline. But sometimes, as in this picture, the tumor can be here, but it could cross over this area called the corpus callosum. There's fibers, and it's like a bridge to the other side of the brain. And so we'll treat a much bigger field, and again, bigger margins on this area. And all these little lines here is just the machine is going around in a full circle. And it may not use all of these angles and fields, but it will use a number of them, and it allows us to really conform the dose to exactly where we want it to be. And we deliberately want this to be a larger margin because we know glioblastomas can just be more invasive. They could have little cells that go out further than the main tumor. So often we add, instead of doing millimeters of margin like we do for a tumor that lands in the brain from another area, we might use centimeters of margin to make sure that we're trying to catch where any cell might be. So the fields can be quite large, and patients do tolerate it well, but we have to give smaller doses over a longer period of time. So this is something that's fairly new. It's been out several years, but it started with recurrent gliomas, and it's now being used up front with newly diagnosed patients in trials. And it's very exciting because it's kind of a simpler device. And I remember when it first came out, and I was at meetings and people would talk about it, and a lot of people were very skeptical about it and thought, it was almost like a sham treatment, but the data was very strong and it kept showing an advantage. And so it's really become more and more the standard of care. And it's called the Optune device or Novacure device. Typically, it starts after radiation treatment, but we now have a trial at St. John's where we're putting it up front with a radiation treatment to see if that will maybe make the radiation even more successful. And the devices started out very large and maybe a little more clumsy, and now they're much smaller and easier to use. It is important to have it on the patient's head, and I'll show you what it looks like in a minute, to wear the majority of the day, 18 out of 24 hours, 22 out of 24 hours. It's really as often as you can, and sometimes that can be very burdensome for patients. And the attachments, which are almost like electrodes, will shift. They're placed over the general tumor area, but they can be shifted not to irritate the skin, and the head is shaved so that they can have a close contact. And this is actually the device over here. And it fits in a carrying case for the patient. And then all these are the electrodes that will fit directly on the scalp. So it's wearable and portable. And it creates what's called these tumor treating fields. And it's not radioactive or anything like that, but it creates a field that interferes with the division of the glioblastoma. GBM is a glioblastoma cancer cell. And they could slow down the cell division, and they could also cause cells to even be destroyed. And it's a very simple kind of basic type of treatment, but it had a significant effect in randomized trials, patients of equivalent types that were randomized after treatment or initially at the time of a recurrence, because unfortunately patients do recur with these tumors, but we still keep treating. And it showed to be successful every time it was used. And it doesn't increase chemotherapy side effects, and we don't think it increases radiation side effects. We're going to study it when we use it with a radiation treatment. It's going to be randomized, meaning that patients will be on the trial randomly assigned to either have it or not have it. And what it showed in a large clinical study is that 50% of the patients using it with the Temidar after radiation were alive at 2 years versus 31%. And I know these numbers are very, low compared to what we see with other tumors, but we're continuing to work at getting these numbers higher. And I've definitely seen such a huge change since I was in training and residency in the 90s and even in the early 2000s, that patients are living longer. We're seeing more patients with both longer quality of life and better quality of life. And even at 5 years, which when I was in training was almost down to 0, and sometimes we can see 5% with chemotherapy alone. This is not necessarily with other treatments that patients will enroll in, but 13%, so more than double, with the Optune device in these studies when they looked at them long term. So we know that this device does have an impact. Again, sometimes it can be a little cumbersome for patients, although it's become much more user-friendly over the years. And it's just really a novel way of who would think of putting something on the head and creating these low energy fields that really affect the brain waves and affect the glioblastoma cells in the brain. And it's been a very reproducible effect that's been seen in multiple studies. And these are just their curves. These are the patients that are on Optune. These are the patients that are on best standard of care. And you can see a definite difference between the two, even going out 5 years. And these were, on a statistical analysis, significant. Well, I wanted to talk about something that's even more recent. And I just became involved in this study. It actually opened at Providence St. John's about 2 weeks ago, and we enrolled our first patient last week. And I wanted to share with you something that we're doing that is very exciting. And it's called intraoperative radiation therapy. And it's best known actually in breast cancer with early stage disease, favorable disease, usually patients that are not necessarily getting chemotherapy or have lymph node involvement. And it's been found to be equivalent to doing whole breast radiation to just treat the lumpectomy site with a balloon that inserts at the time of surgery. And there's a feeling that you can give a high dose because it's a small area. It's not the whole breast, but it's just the lumpectomy site. and you're placing it on this open raw surface that's just been resected by the surgeon. And there isn't a chance for this healing process. And sometimes when tissue heals, it can kind of protect the tumor cells as well. And it's been amazing for breast patients because instead of coming in for 4 to 6 weeks of treatment, they can be done at the end of surgery. Now, of course, it's for select patients, and we have a very active program at Providence, St. John's, and City of Hope also offers this as well. And it's great because it's so much easier on the patient. There's usually a little less side effects because there's not the volume of tissue that's affected, although patients heal up very well from whole breast radiation. And patients just love, going in for surgery and having their surgery and the radiation at the same time. And it only adds about 10 to 15 minutes to the whole procedure of the surgery. And there's an X-ray tube that will go into the balloon. I'll show you in a minute. And we'll give the dose, and then everything's taken out, and then the surgery proceeds as normally. But we're looking at it for glioblastoma patients, and GBM is the abbreviation for that, to see if there's if this kind of blast of a large dose for this tumor that's been more challenging to control, really the complete opposite of breast cancer, but it may this concentrated dose may overcome some resistant or recurrent cells. So the study is actually open for recurrent glioblastoma multiforme patients. And we usually do start trials not with newly diagnosed patients where we have good standard of care treatment that we know has, had studies and support, or clinic, but as we usually start new treatments with recurrent tumors and then kind of work our way up, just like with the Optune device. So the brain IORT data was actually just presented this last August, and it showed that IORT improved overall survival in recurrent glioblastomas. And in patients with the most favorable surgery, less than 2.5 cubic centimeters, so a small amount or less was residual after surgery, because again, people can't always take everything out because of the sensitivity to neurologic structures. The median progression-free survival, the local progression-free survival, in other words, coming back again in the site where the tumor was initially, was 16.5 months with the IORT versus 8 months in the standard of care group. And they looked at overall survival, all comers. Now remember, this was a very small trial. This data was out of Europe and mostly out of Russia, actually. And it was very exciting through technology and our meetings we were able to actually have in developing this trial with the Zoff company. We were able to actually speak to the Russian scientists, which was really, just a very lovely collaborative. And the overall survival was 21 months versus 11 months for this favorable group, less than 2.5 cubic centimeters of residual tumor. And even though we're giving a very large dose, the toxicity was actually less in the IORT group compared to other things and other treatments. And for all patients, the overall survival was 11 versus 8 months. So not a huge difference, but still consistently better. And the local progression-free survival was 8 months versus 6 months. But in patients with IORT, they lived anywhere from 4 to 54 months. Remember, these are patients that have already failed conventional treatments. But the control group is around 2 to 22 months, so almost half. And when this data was presented, there were still some IORT patients that were still alive and being tracked, but all the patients, unfortunately, in the control group had succumbed to their disease. So the data looked very, very promising, and we want to do a more national trial, do it at more centers and throughout the United States, and Providence, St. John's, and the Pacific Neuroscience Institute, St. John's Cancer Institute. We go by a number of names. They're all under the mother of Providence, St. John's. And we have become part of this national trial. And it's called the Gliox protocol for glioblastoma. And we try and do the safe maximal resection. There's a drug called Avastin, which helps with tissue breakdown, necrosis, inflammation that's given postoperatively. we give the intraoperative radiation therapy at the time of surgery. It's for patients that have recurred. So patients had to have one course of conventional treatment or conventional treatment with another protocol, but we don't see them at the 5th or 6th recurrence. We see them at the first time the tumor comes back. And they have to meet critical guidelines. Some tumors are very close to the optic chiasm. That's where the nerves cross from both eyes. So if you damage that, you could actually affect vision, peripheral vision in both eyes, or the optic nerves from one eye, or the brainstem that controls a lot of our general breathing and well-being and function and nerves to the face. So if the recurrence is right on top of those structures, we have an issue and it's not the best treatment and we wouldn't enroll the patient. But if the tumor is a centimeter or more away from these structures, and that's pretty small and we can see that, then those patients would be eligible. And it's done through the Xoft is the machine, the Xoft Accent electronic brachytherapy system. And we just feel that the environment at the time of surgery is much different than when patients come back as an outpatient for treatment several weeks later. Not that we don't overcome that, but we feel that may be part of what's giving this advantage to IORT. It's a large dose. We can see exactly where it's placed and it's attached to the machine. And there have been multiple individual studies, not so much in the US, but in Europe and where they have really looked at small trials of treating patients that have recurred. And there's multiple balloon sizes and volumes. So all these dosages are pre-calculated because we don't want to be running a plan for an hour with a patient under anesthesia with the brain exposed, but we've kind of anticipated whatever size cavity there might be, and we have them all programmed in, and we can pick one depending on the size of the balloon and the number of cc's that the neurosurgeon is able to put in. And this is the machine. It rolls right into the operating room, so it can kind of get into a sensitive sterile area. We stand over here, and this is our monitor to plug in everything there. And it's not too large. It kind of comes up to your shoulders. And this is the balloon that's placed. So this will actually go into the brain cavity. This went into the breast cavity, and it's filled with fluid, and it's attached to an X-ray tube, a very low energy X-ray tube that will be programmed to go in and sit in the balloon at different dwell positions along the length of the balloon and give this dose of radiation, which is typically 2000 centigrade in one setting. And then afterwards, the balloon is deflated. It's detached, and the balloon is deflated and taken out, so to not irritate the tissues at all. And these are just some pictures. This is from our first case. And I believe, I don't know if you could see on the bottom, but I'll have another picture, that we're the first institute in the US to do this for a primary brain tumor. It has been done for some metastases to the brain, but for a primary brain tumor and on this protocol. So we have the CTs and MRIs up in the operating room. And this you might see better. So this is where this patient had his tumor before, and that actually is well controlled from the previous radiation, but the tumor came back just behind it. And this was in the treatment field, but unfortunately, probably didn't get quite as high a dose as where the main tumor was, and unfortunately came back in the same area, but a little posterior. So we didn't give IORT here, which would be closer to the brainstem and the eyes here, but we gave it more posterior, far away from the brainstem, well over 1 centimeter. And this is again, front to back, and this is facing in. Now, the next couple of pictures I'm going to show are actually from the operating room from just last week. And if anyone is a little queasy or sensitive, you might want to look away. The first picture will be just kind of an overview scene of the OR, just showing the balloon sticking up, but I will have a picture where you'll actually see the balloon in the brain tissue, which will be the second picture or second slide. And you could see a lot of wires coming out and some raw tissue. And that's just, we're tracking the neurologic function to make sure that that safely recovers afterwards. So just a warning, if you're queasy, maybe to look away. And I certainly don't want to upset anyone. So this is the OR. These are some of the sterile tables. This is under these drapes, these sterile drapes. This is the balloon, and it's coming out. It has to be placed directly. Sometimes it might be at a different angle, but in this patient, it came straight up, and then we angled from above, as you'll see in a moment. And then this is the picture that's probably the most sensitive. This is actually a close-up of the balloon in the brain tissue with the wires tracking neurologic function. And once it's secured and safe, then we put the other drapes and things over it. And then this is the device. This is the front of the device. And this is an arm that can go up and has joints, and we could actually come in and attach. Now, when we do breast, it's much easier. The breast tissue is less sensitive. We can rotate the patient, but we don't want to move the patient. You know, they're in a kind of a frame so that the neurosurgeon knows where they're operating. And so we have to be very, very sensitive. But this was very successful. There was no bleeding, no issues, and we're very pleased with how it went, both technically. And we just felt very good about the case in general. And we'll see how this transpires over the course of the trial. But there were no major complications with this. We want to make sure that the balloon didn't irritate the tissue. And we ultrasound at the time in the OR. There's a little ultrasound that can go right in, and there's a screen on the side, and we can actually see how the balloon fits in the brain tissue to make sure there's no air gaps and that it's contacting the surface well. And this is the last of, so we've just enrolled our first patient, and we will be doing this as an active participant in the trial. And there are other centers throughout the United States as well. So really, when we talk about the latest, that is the most recent. I'm going to switch gears again and talk about meningiomas, because we do see a lot of these tumors. They're not that common, but we see a lot at our different centers. And again, they're often, these are the benign tumors of the meninges, but they can be aggressive. They are grade 1 to 3, where 1 is benign, 2 is atypical, and 3 is anaplastic or malignant. They look more aggressive under the microscope. They have more growth rate. They can present with seizures. They can recur and be problematic. And usually they're resected or watched. If they start to grow, we add the radiation in. But this is a very different field that we use. Instead of those large fields that you may remember from the primary brain tumors, these are along the lining of the brain, sometimes at the sinuses towards the surface. So very contoured in, away from, this is the brainstem here, away from the eyes. This is a side view looking at the side of the head. And so they're up by the lining, and the lining will come down, and that's why you see these come in. They look like they're going into the brain, but they're actually aligning with the lining of the brain. They're the fields are right along the meninges that cover the brain. And this is a view from the top. So they're not getting as much of the brain tissue, but they're kind of coating, and the dose goes around it, just like the meninges does. And these can be very successfully treated too. And this is something I wanted to show. When we do treatments, we run something called a dose volume histogram. And so what we want to make sure is we know what dose goes to what volume of a structure, because radiation is always a balance between dose and volume. So we want to have our targets over here getting the full dose, and we want to have the other structures, normal structures, all the way on the other side here. They'll get some dose, but much less. And that gives us a therapeutic window where for each treatment we give, the tumor's seeing much more of it than the normal tissue. And we always are adjusting that balance to come up with safe treatment. I wanted to talk just a little bit about brain metastases. And again, when I was to date myself, was when I was in training in the 1990s, whole brain radiation was practically used for everything. Stereotactic treatments were just starting to come out, but very limited. It could only be given if you put a frame on the patient. It was one treatment. It usually took the whole day. But now we can treat multiple areas. And sometimes we will treat with stereotactic. There's still a role for giving whole brain treatment, and it's whole brain radiations had kind of a bad reputation, but in the right hands and in the right situation, it can be very, very helpful. Sometimes tumors like small cell lung cancer, where the whole brain is at risk, we might use, although there's more systemic treatments that are helping us control the brain, and we could make the radiation smaller. When the tumor involves the CSF fluid, when we do need to give these treatments, because we have something called IMRT, or intensity modulated radiation therapy, we could do something called hippocampal sparing. And the hippocampus runs on both sides of the brain, along the brain stem, and it supposedly helps with memory and fatigue and just well-being. And if we can spare that, bringing the dose down to probably 50% of the prescribed dose, patients have been found to recover faster from whole brain radiation, something that wasn't done many years ago. And there's been a radiation oncology group study on a pill called Namenda, which is used for patients with Alzheimer's and different things. It was actually used as an antiviral pill many years ago, but it's been used with radiation. The treatment may be a few weeks, but the patients take it for 6 months. And it's also been found to decrease fatigue and memory. It kind of supports the brain. So even if patients need whole brain treatment, we can do it effectively and with less side effects. And this is just a 3D conformal, very uniform dose of treatment. The red is the 100%. It's not completely uniform, but it's very uniform compared to what you'll see in a minute. This is another X-ray of the brain. But when we do hippocampal sparing, we do a much more complicated dose. And as you can see, all these wavy lines, it's less homogeneous, but it's still giving a very good dose in. And over here is where the hippocampus is. And this purple is a 50% line. So we've really dialed that dose down. And that's through the technology of new radiation techniques that we can selectively pick a part of the brain and bring the dose down and still give the full dose to the remainder of the brain. And that's cut down a lot on toxicity. Now, if the tumor's in the hippocampus, then we don't want to do this, but most of the time it isn't. And we can do this and still give doses to where we need to give our dose to the part of the brain that's involved. And this is just, again, from the front and back, the hippocampus here going at about 50%. So it's really allowed us to spare toxicity in a treatment that has had issues with toxicity, whole brain radiation. Now, when we do stereotactic, compared to what we just saw, which was treating the whole brain one way or another, we now are going to very small areas. These are the 3 ways we look at the brain: front to back, straight on, and from the side. And this is a small lesion that was treated. And this is just a schematic of how the machine goes around. And these are, again, pictures. These are all the different fields that we can really spare. Think of that first picture I showed you, the glioma with this large field and all the lines. We can get it very, very tiny to where the small area is here. And we can treat, used to be you do it for one lesion, or if they had 2 lesions, and someone arbitrarily kind of came up with 4 lesions. But it really depends how many there are, where they are, how the plans come out. And we've even been able to do this with patients with over 10 lesions. It just depends on where the lesions are and how we set it up. Because if we can spare patients from whole brain radiation, we like to do that because it's just a little less fatiguing, even with the hippocampal sparing and the Namenda. But these are just some examples we can treat over here and in these areas. And I think in this patient, we had treated this before, and then they came up with 2 other lesions. And so we just block out this area and we can treat again. So if someone recurs, we could still do these very conformal types of treatments. And this is another example where we may have treated over here and we bring the dose away from where we treated before and can treat new areas. And so it really just takes some juggling of what was done, but through computer technology, which is wonderful, we can merge in what was treated before, what we're planning to treat, and we could really see where the overlaps are. We can bring in the doses and the structures from before, so we feel very confident that we're not overlapping, or if we are overlapping, we may not treat, or we may adjust the dose again from the previous treatment. But it gives us a lot of flexibility, which helps patients out. And many of these patients who had brain mets, who it was felt to be their life-defining event, are now living and doing very well, and these are treated and they move on with their treatment or can get off of treatment. And so patients don't necessarily at all succumb to brain metastases. They can be treated and they can live on. And these are, again, are lesions that are spread from other areas of the body, from a tumor that was in another area. It may not be active at that time, but from breast or lung or melanoma somewhere else. What I wanted to talk about is a little bit, just in wrapping up, is how we evaluate how effective these treatments are, because I know getting scans and wanting to know if the treatment works can be very stressful. And sometimes as the physician, we have to come in and the patient expects, well, does the scan look good or does it look bad? And what does it show? And sometimes we can't always tell you that immediately, that sometimes it's hard to interpret the scan, but through serial scans, through 2 months later and 2 months later again, we're able to distinguish. And through some state-of-the-art imaging, we're also able to see more clearly. And I wanted to show you an example of that. But especially in glioblastoma patients that are methylated, which are favorable glioblastomas, you could see something that's called pseudoprogression. And usually on the first scan, but sometimes even 6 months or 2 years down the line, there can be inflammation that looks like the tumor is angrier and bigger, but it's actually just responding and breaking down from the treatment. And now that patients are on many more medications and targeted agents after treatment, we're seeing this even later on, and we always have to take that into account. So it's really an inflammatory reaction, can be very favorable, but it could look really bad on the imaging. So sometimes we have to interpret it and tell the patients, even though your images look worse, you're actually doing very well. And spectroscopy looks at different peaks of chemicals, where with radiation scar tissue, there's a peak in the lactate. With tumors, it could be a peak in the choline, or the PET brain looking at the activity of tissue will distinguish it. We see it also with metastases. And again, we're seeing it more because patients are on more drugs are available that cross the blood-brain barrier, which is good. And this is just an example of a very small lesion that measured about 10 by 7 millimeters and was treated with a single fraction of radiation, just to this area, very, very focused beams. And again, front and back, and the brainstem is right here. The eyes are here, very safely treated. And this is the dosing that was done. So very, very localized, with the field going all the way around. And usually for stereotactic treatments, it's not weeks of treatment. It could be 1, 3, or 5 treatments. And then here you could see it, it's a little bigger, 11 by 8, it was 10 by 7. And you see this kind of enhanced rim. It's more white around the area, showing some activity. And then on a following scan, and this is all kind of in the first year of treatment, it looks much larger, but it looks kind of what we call moth-eaten. You can see that there's some little spots here. It's not as dense. That sharply defined rim is kind of blurring out. And now it's much bigger. It's 16 by 17 millimeters. So what we did, we felt this was just radiation effect with medicines that the patient was getting. We did a spectroscopy, and they actually the radiologist will align it right over the tumor and look at these different peaks. And it did turn out to be a radiation reaction. And there's a report, and they look at what the perfusion is, what the choline and lactate and the ratios of a number of different chemicals are to determine if it's most likely radiation or most likely active tumor. And that can be very helpful. But sometimes we can't tell you as the patient immediately that it was successful. We think it is, but we have to run these other scans. We have to follow it with additional scans, because sometimes as tumors respond, they can look worse on the X-ray before they look better. I just wanted to talk a little bit about radiation side effects. There can be some fatigue, some hair loss. Usually now with current techniques, the hair will grow back. It could take several months, usually longer than chemo, but will come back. And occasionally when we stir things up in the brain, we can get some nausea or vomiting or headache, and we can give some medicines to control that temporarily. We talk about cataract formation, although it's not something that I see clinically very often, but it's just as repairable as any other cataract. And the risk of damaging the brain in any of these types of treatments is usually less than 1% from the radiation itself. But there is a term called radiation necrosis. And that's something that we see as just breakdown of tissue. We can see it incidentally. Sometimes patients get a little headache on it. We can treat it with some steroids, usually a short course, but very rare that it would be resistant to medicines or just time for healing, and the surgeon would have to go in and remove it. That's really less than 1 or 2% of the time. And it's very rare. I mean, I see maybe once or twice where patients who didn't have seizures before can have a seizure from the radiation, from the irritation, but that's actually very rare as well. So we covered a lot of ground today, and you've seen some really groundbreaking things, and that we're thrilled to have available to patients in the community. And it's just good to know that brain tumors can be very diverse, from benign to malignant to primary to secondary. But we're always looking at multiple ways to treat these. We use all the latest MRI and CT planning and spectroscopy and PET to really get an idea of what's going on in the brain. And the fields can be as tight as we need them to be, and sometimes they need to be larger, like for initially treating glioblastomas or treating patients with disease in the spinal fluid. But overall, patients can do very well. I know there's always a fear about going in with the brain, but because it's a obviously very important organ. But through the way that we can deliver it and plan it and coordinate it with the other treatments, patients can respond and heal very well. And certainly a rapidly advancing field with so many new treatments and medications, and looking at the DNA of tumors and putting these all into clinical trials, which are available at all these institutions. So thank you very much for your attention. I'm always happy to answer questions as best as I can. It's my City of Hope and Providence email. And I think we'll open the floor if there are any questions. Thank you so much.
Thank you so much, Dr. Chaiken. That was absolutely wonderful. I apologize. I was just putting your email into the chat, and it looks
yeah,
like I
please.
spelled it wrong. So let me fix that. All right, both of them in. My apologies. While I'm doing so, please take the moment to enter any questions that you have for Dr. Chaiken into the Q&A feature. We have time for a couple questions here. And just a reminder that this webinar is also being recorded, so it will be up on our website in just a couple weeks. And I will also put that into our chat, our website. And we'll give it another minute while questions come in here. And I'll use that opportunity to also mention that we also have a brain tumor support group at CSCLA. For any social or emotional support, please feel free to reach out to us. I will also put our email into the chat, but for those of you who are watching this later, our email is info@cancersupportla.org, and we'd be more than happy to get you connected to some of our support groups there. Well, it looks like we don't have any questions just yet for you, Dr. Oh, here we go. I spoke too soon. Okay. So someone has a question about timeliness. They said they've been in the midst of very slow action by PCP in regards to referrals, insurance, etc., to get a neurosurgeon for a biopsy result suggestive of diffuse glioma. Would this be a situation where urgency is warranted?
Yeah, it's very hard. I mean, regardless of the insurance, sometimes we've found, and especially recently for some reason, that it just seems to be slower getting patients through the system, even people that don't need authorizations, even just getting, tests and scans scheduled. I don't know if it's a shortage of manpower or more people are, just coming out after COVID, and that we're diagnosing more things. But I mean, I think, certainly as physicians, and as patients, we always like it done yesterday, and things don't move that rapidly, but sometimes it really helps, never feel bashful about calling your primary care office and, saying, did you get an authorization? And sometimes something's there and you could get it before it takes a couple more days to get to you in the mail. And, a diffuse process, it's hard to know exactly what that means, but it's certainly something where you would want to see a neurosurgeon. and who could start you on the process, and a neurologist, a neuro-oncologist, hopefully. So it's very challenging. Again, things don't move that rapidly, but just to allay anxiety, it would be nice to get in sooner than later. And but I would just keep talking to your primary care doctor. Sometimes you could be referred to an oncologist depending on the situation, and they can get it going faster too. But don't be shy about calling, or even calling your insurance directly and telling them that, hey, I have this diagnosis and I really would, I'm very anxious about it and I need to have it worked up, and it seems to be taking a long time. Because sometimes we will put in for authorizations and things, and if we hit a wall, we'll ask the patient to call it. Sometimes magically the authorization comes right through. So it's always a group effort. But I think as long as they keep moving it along, that should be good. But we do want to, move in a timely way. It can be very challenging and frustrating.
So our next question here, someone is asking, their husband has a GBM, and he has just finished 6 months of CRT and has developed blisters on his feet, back, and chest. She's wondering if this is a typical side effect.
It's radiation side effects with skin reaction, which you can cause, are usually only in the radiated field. So it doesn't sound it's the feet, back, and chest. It sounds like it's a drug reaction. And some of the newer drugs can cause that. The radiation would probably be at most over 6 weeks, but maybe the medicines and everything were longer. I would certainly make sure that the doctor prescribing the medications is aware of the rash. And sometimes these rashes from drugs, I've seen it with immunotherapy drugs. I don't know if that's maybe what's being used. You really need to get a dermatologist involved, as well as the prescribing physician, to help, because that can be very uncomfortable. It's not a common reaction from the radiation. We do see some hair loss and a little bit of redness, but not that dramatic a rash, and that would be well out of the field. So it sounds like it's something from the medications, but I definitely would make the prescribing doctors from the 6 months of treatment know about it, so they can treat it. But some of these, you do need to be on a combination of creams and even oral medicines to help quell it.
But another question I have for you is, you talked a lot about new trials and new technology that has come out during your presentation. Do you have any advice for those who are thinking about it, about the best questions they can ask their doctor to see if it's a good option for them?
Yeah, excellent question. I do think you should always ask, do you have a clinical trial? Do you have another way of approaching this? Because some patients will think, I don't want to be a guinea pig, but you're not. You're really trying to advance your own health as well as the field. And many of these trials will incorporate what we know and add one thing different that may give a much better response. And, I think they always should spend time with you to go over the side effects, to go over what the drug involves, what extra time you'll be in the clinic. But usually on trials, you're followed very closely, so you'll get very good follow-up. There's scans at regular times. So which is also good just for your general health care. But I would definitely ask, do they exist? What have they shown? And also, is it a trial where you automatically get the new type of treatment, or are you randomized either to get best standard of care or the new drug? Because I know that can be, hard for patients to decide, because sometimes we just don't know if these drugs are better, if they could be harmful. So it's compared to the best standard of care. But some patients think they will automatically get it, and then they don't get it because of the randomization. It's a arbitrary process, and you want to be aware of that going in. And physicians will always treat you regardless. There's no penalty if you decide to go on the trial or not. There's always, standard of care treatment. And also just to ask if there's an in-house trial as well as what they have in terms of national trials.
It looks like that's all the questions that we have for today. Thank you so much, Dr. Chaiken, for taking the time to be with us.
My pleasure. Pleasure.
That's
Thank you all who attended. Sorry I can't see you or interact with you completely, but hopefully in the near future we'll get back to some norms
Oh,
and just
so
everyone be very safe.
absolutely. Well, thank you so much and have a wonderful rest of your day.
Yes, to all of you. Thank you. A pleasure. Take care.
Thanks for joining us.
Bye-bye.